Welcome back to AIHA Connected, our online patient conference. My name is Erin Anderson, and I'm the Director of Programs and Advancement for the Autoimmune Hepatitis Association. It's my pleasure to introduce Dr. Dania Brigham, a pediatric hepatologist from the University of Colorado School of Medicine. She will speak about what families can expect when their child is diagnosed with autoimmune hepatitis. Welcome, Dr. Brigham.
Hi. I'm Dr. Dania Brigham. I'm an assistant professor at the University of Colorado School of Medicine. Today I'll be talking about pediatric autoimmune hepatitis. The title of my talk is, My Child Has Autoimmune Hepatitis. What's next? The outline of this talk will include an overview of autoimmune hepatitis, presentation and risk of cirrhosis at diagnosis, treatment goals, standard treatment, second-line treatments, withdrawal of therapy, and long-term outcomes. So let's first review what autoimmune hepatitis is. Autoimmune hepatitis is a condition where the body's immune system attacks the liver by mistake. Immune attack leads to inflammation in the liver, which can eventually lead to damage such as cirrhosis and liver failure. However, there are treatments that can prevent this damage in most cases. In general, the findings that characterize autoimmune hepatitis include elevated transaminases, AST and ALT, and elevated IgG, autoantibody markers, so either ANA and or smooth muscle antibody in type 1 autoimmune hepatitis, or liver kidney microsome antibody in type 2 autoimmune hepatitis, and interface hepatitis on histology, so you need a liver biopsy to confirm autoimmune hepatitis. So why is it important for us to talk about autoimmune hepatitis? Well, because we know that the prognosis is not good without treatment. So this makes that early detection and treatment very important. Let's talk about how autoimmune hepatitis presents. So about 30% of patients will have an asymptomatic presentation, just incidental finding of elevated transaminases on routine labs. About another 30% will have what we call an acute viral hepatitis-like presentation, where they'll feel fatigue, malaise, abdominal pain, nausea, vomiting, jaundice. Another 30% will have a more insidious presentation, like more progressive fatigue, weight loss, intermittent jaundice for months. About 10% will present with portal hypertension, so that means splenomegaly, a big spleen, ascites, fluid in the belly, or variceal bleeding. And then finally, about 1 to 2% will present in acute liver failure. So let's talk about the risk of cirrhosis at time of presentation. The literature shows that 38% of children will have cirrhosis at time of presentation, which is a little bit more than what is expected in adults. Cirrhosis is present in 28 to 33% of adults at presentation, and especially true in the elderly population. Before we talk about treatments, it's important to discuss treatment goals. So in the past, attaining transaminases levels less than 2 times the upper limit of normal was considered proof of remission, but it is now clear that patients with abnormal transaminases still have progressive disease. So what is biochemical and histologic remission? Biochemical remission means normal labs, so normal AST and ALT for at least 2 years. Normal IgG levels, that's helpful to check prior to considering repeating liver biopsy or withdrawing therapy. Negative or low titer antibodies, which is not standardly tracked. And then prior to considering withdrawal of therapy, we must repeat a liver biopsy to confirm histologic remission, which means no liver inflammation on liver biopsy. So what if there is a lack of response with the treatment? Then we need to reconsider the diagnosis. Could it be Wilson's disease, non-alcoholic fatty liver disease, primary sclerosing cholangitis, or toxicity to the liver? Let's look at overall outcomes. The majority of children reach remission within the first year of therapy. However, lifelong treatment is necessary in the majority, and one can anticipate an excellent quality of life while on low-dose maintenance medication. Up to 40% of patients will have an episode of relapse during treatment, and those risk factors are alternate day steroids, puberty, or non-adherence. What are the predictors of treatment response? So how fast you respond to treatment is the most important index of outcome. So we want to start seeing those liver tests improve within 2 weeks of starting treatment. So often we do individualized adjustments in therapy in order to improve and speed up response. Biochemical remission, which is, again, normal liver tests, achieved within 6 months is associated with a significantly lower frequency of progression to full-blown cirrhosis or the need to go to liver transplant. Let's review standard treatment. Standard treatment is a combination therapy of corticosteroid and azathioprine. Corticosteroids are used to induce remission. Azathioprine is used for maintenance therapy. Patients with fulminant hepatic failure or end-stage liver disease who failed therapy will likely need to go on to liver transplantation. Let's first talk about corticosteroids. We usually use prednisone or prednisolone. The dose is 1 to 2 milligrams per kilogram per day with a max of 40 to 60 milligrams daily. We usually decrease this dose weekly to every 2 weeks if transaminases are improving. It may take 3 to 6 months for biochemical remission. Prednisone is typically weaned off within about 6 months from the start of treatment. It induces remission in about 80% of cases, and that's based on looking at the ALT alone improving. The side effects of steroids include cushingoid features, acne, mood changes, trouble with sleep, weight gain, adrenal insufficiency, weak bones, diabetes, and hypertension. We've also been using budesonide as a corticosteroid for remission. In a randomized trial of newly diagnosed autoimmune hepatitis patients who were started on budesonide in combination with azathioprine, they achieved laboratory remission after 6 months with fewer side effects compared to the prednisone group. There are less side effects because budesonide has a 90% first pass effect on the liver, meaning there's little that goes systemic. A potential long-term benefit is the preservation of the bone mineral density and less fractures. Patients with acute liver failure or cirrhosis were not included in the randomized trial of budesonide. Therefore, we do not use budesonide in those patients. Patients with cirrhosis should not receive budesonide because the liver would not be able to process it, and there might be shunting of it away from the liver that may reduce drug efficacy and promote steroid-specific side effects by allowing the budesonide to bypass the liver. Portal vein thrombosis has also been reported in patients with cirrhosis taking budesonide, although hard to tell because portal vein thrombosis is a known complication of cirrhosis, independent of budesonide use. Patients who fail to normalize their lab tests on prednisone are also less likely to respond to budesonide, so this is not a rescue therapy for steroid refractory autoimmune hepatitis. Now on to standard maintenance treatment with azathioprine. The dose is 1 to 2 milligrams per kilogram per day. It takes about 6 weeks for it to reach its full effect. You need a thiopurine methyltransferase or TPMT enzyme check prior to starting to make sure you can metabolize the medication. Patients typically need to be on azathioprine for 2 years with normal labs prior to considering withdrawal of therapy. The side effects include GI upset, hepatotoxicity, meaning liver toxicity, myelosuppression, so bone marrow suppression, so low white count, platelet count, hemoglobin, pancreatitis, rash, infection, and malignancy. What if you don't respond to the standard therapy? Well, second-line treatments have been used to manage treatment failure or incomplete response, and that means anything other than complete biochemical remission, which is normal AST, ALT, IgG, and for drug intolerance, so the inability to continue therapy due to side effects of the drug. Most children with autoimmune hepatitis respond well to standard therapy, but 10 to 20% require second-line agents to achieve remission. Patients who are unable to normalize liver tests and liver tissue within 36 months have a higher frequency of developing cirrhosis and need for liver transplantation. Some of the second-line treatments we'll be talking about are MMF or CellCept, Tacrolimus, rituximab, and infliximab. MMF or CellCept is mostly used in patients who are intolerant of azathioprine. It's more effective in that group than in the group of patients with treatment failure on standard therapy with glucocorticoid and azathioprine. One study comparing multiple groups on different second-line therapies showed that 36% of children had normalization of ALT and AST by 6 months. Some downsides of MMF is the cost. It's 15 times more costly than azathioprine, and it's teratogenic, so it can cause birth defects. The side effects of MMF include GI symptoms, myelosuppression, so low white count, platelets, hemoglobin, lymphoma, skin malignancy, and infection risk. Tacrolimus is another second-line treatment that is used. It's a calcineurin inhibitor. Studies on the use of tacrolimus in the setting of treatment failure, incomplete response, and azathioprine intolerance have confirmed its efficacy. One study showed no real significant difference in remission rates between CellCept and tacrolimus. The side effects of tacrolimus include neurological symptoms such as tremors and headaches, some renal toxicity, hypertension, renal insufficiency, diabetes, and hair loss. So based on superior ease of use and side effect profile, a trial of CellCept over tacrolimus as the initial second-line therapy is usually what we do. Then we get into evolving salvage therapies. In children or adults with autoimmune hepatitis who have no response to first-line treatment, the accuracy of the original diagnosis and the medication adherence should be reevaluated. Rituximab and infliximab are possible alternative therapies after first-line and second-line regimens have failed, but the data supporting their use is very limited. Rituximab is an antibody to CD20 cells which depletes B cells. Side effects include infusion reactions, cytopenias, so low cell counts, infection risk, and severe mucocutaneous reactions. So while the published data is very limited, surveys and real-world experience indicate that many centers are using rituximab for very difficult cases. Infliximab is an antibody that binds to TNF-alpha. There's a weak evidence on efficacy and a very increased risk of infection, especially in patients with cirrhosis. It can also cause liver injury and even cause a drug-induced autoimmune hepatitis-like injury. Now that we've talked about therapies, let's discuss conditions and timing for withdrawal of therapy. Withdrawal of therapy can be considered in patients who have been on treatment for at least 2 years with biochemical remission, so normal labs. Once a patient achieves biochemical remission for 2 years, then they need a repeat liver biopsy to confirm that there's no more inflammation in the liver. If they have confirmation of normal liver pathology, then they have histologic remission. Even though biochemical remission is usually achieved within 6 months of therapy, histologic remission usually takes much longer. For type 1 autoimmune hepatitis, 65% of patients will achieve a histologic remission by 18 months of therapy, and 80% by 3 years. Type 2 patients rarely can be taken off medication. Even after proven histologic remission in type 1 autoimmune hepatitis, if a patient goes off all therapy, 70 to 80% will relapse within the first year, requiring reinitiation of immunosuppression. So it's really important to watch labs closely during treatment withdrawal. Most relapse happens within the first 18 months, but it can also happen up to 10 years out. In summary, drug withdrawal and achievement of a long-term medication-free remission of autoimmune hepatitis are possible in a minority of patients with type 1 autoimmune hepatitis, about 20 to 40% of patients, and rarely in type 2 autoimmune hepatitis. In patients treated for more than 4 years before stopping therapy, the sustained remission was 67%, compared with only 10% remission if meds were stopped in the first 2 years of treatment. There are no clinical or laboratory features that can predict who will relapse after stopping medication, so frequent monitoring of symptoms and liver tests is warranted in the first 2 years after withdrawal and annually thereafter. Relapse occurs in 60 to 80% of children after drug withdrawal. That's compared to about 50 to 87% in adults. Relapse is typically asymptomatic and only detected by mild increases in AST and ALT level, and responds very well to retreatment with the original regimen. The main risk of relapse are related to the delay or failed detection, which can result in an increase in liver scarring or fibrosis in 10%, and clinical deterioration in 3%. 50% of all relapses occur within the first 3 months after drug withdrawal, and the frequency of relapses decreases after the first year to 3% per year over the next 3 years. 90% of relapses occur within 28 months, but late relapses are still possible. Cirrhosis develops more commonly in patients with repeated relapses after drug withdrawal than in patients who have relapsed once and been treated. And liver transplantation is also more common in that group. The main predisposing factors for relapse are the duration and completeness of inactive disease prior to withdrawing treatment. Many other factors have also been proposed, include psychological stress, concurrent autoimmune disease, treatment with multiple agents, increased ALT and IgG levels at drug withdrawal time, the specific plasma cells in the liver tissue pre-withdrawal, delayed biochemical remission, and using only prednisone as monotherapy. Treatment failure implies worsening of clinical or laboratory parameters despite appropriate medical treatment. This occurs in 10% of patients. They develop signs and symptoms of end-stage liver disease, including portal hypertension with splenomegaly, big spleen, ascites, fluid in the belly as pictured, and varicose bleeding. In children, the development of end-stage liver disease requiring liver transplantation has been reported in 8.5% of patients up to 14 years after diagnosis. The overall 10-year survival rate of treated autoimmune hepatitis in a non-transplant center is 91%. Factors that may affect the treatment response and long-term outcome are age at onset, ethnicity. For example, African American patients have more advanced stages of fibrosis at presentation than white American patients, and malignancy. Hepatocellular carcinoma can develop in 1 to 9% of patients with autoimmune hepatitis and cirrhosis. The indications to consider liver transplant in the setting of autoimmune hepatitis include patients with end-stage liver disease who fail treatment, which happens in about 10% of children and adolescents with autoimmune hepatitis, patients with acute on chronic liver failure, and patients who present with fulminant hepatic failure. Autoimmune hepatitis accounts for 2 to 3% of all pediatric liver transplants, and up to 20% of all cases of pediatric fulminant hepatic failures. Patient survival is similar in pediatric and adult patients up to 50 years of age. Autoimmune hepatitis can recur after liver transplantation in about 8 to 12% of patients within the first year after liver transplant, and 36 to 68% after 5 years. In summary, these are the takeaway points from this talk. Most patients respond to standard therapy. Budesonide is a great option to consider for remission in patients who are at high risk for steroid side effects, such as obesity. No budesonide in the setting of cirrhosis. Histologic remission takes longer than biochemical remission. In those patients that do not respond to standard therapy, CellCept is a reasonable second-line therapy. Tacrolimus can be reasonable step-up therapy if it seems to be quite aggressive or progressive. Biologic meds are starting to be used with more frequency and may be considered in special cases. Long-term treatment-free remission is possible in a minority of patients with type 1 autoimmune hepatitis and rarely in type 2 autoimmune hepatitis. Relapse after drug withdrawal is common but can be treated. And finally, liver transplant might be needed in some cases and outcomes are overall good. Thank you for your time. I hope you enjoyed this talk.